Welcome to the CAEP 2018 vlog. I'm your host, Chris Bond. And yes, I do work permanent night shifts. That explains the skin. I don't have profound anemia. I got it checked. I'm coming to you from Transylvania. No, I'm coming to you from Calgary, Alberta. And today we have a chance to talk with one of the plenary speakers for CAEP 2018, Dr. Jeff Kline. Most of you probably know Dr. Kline as the supreme guru of venous thromboembolic disease research in emergency medicine, notably pulmonary embolism. Dr. Kline received his MD from the Medical College of Virginia and then did an emergency medicine residency and research fellowship at the Carolinas Medical Center. He is currently the vice chair of emergency medicine research as well as professor of physiology at the Indiana University School of Medicine. He is the editor-in-chief of academic emergency medicine, and his research interests focus on blood clots, the people who get them, and the people who help diagnose and treat them. Welcome to the CAEP vlog, Jeff.
It's great to be here. Look forward to talking about it.
So, Jeff, you're one of the plenaries at CAEP 2018. Can you tell us a bit about what you're talking about and why it's important?
What I'm talking about is a compilation of 20 years of experience, both working in the emergency department and the research that I've done, particularly in the approach to the diagnosis and exclusion of pulmonary embolism. In a nutshell, it's going to be about what we do as doctors that can improve the patient's experience with less testing. In other words, I call it improving the therapeutic index of the diagnostic experience through using empathic communication, which starts with our ability to recognize nonverbal cues that the patient gives, as well as the words that we use to engender trust and dignity and really show clinical wisdom to patients. And through this, I think we can do less testing, improve patient satisfaction and trust, and ultimately end up with better outcomes.
That sounds really great. Is there any literature on this, and does this work?
Well, when it comes to empathic communication, you'll hear lots and lots developing around the fact that if you can improve primary care physicians' ability to communicate empathically, that there's better outcomes in terms of chronic disease management. Even one paper that shows that trauma patients are more likely to adhere to their therapy once discharged. So empathic communication, which is about the ability of the doctor to walk in the patient's shoes, or as Harper Lee stated in To Kill a Mockingbird, to crawl around inside, or to crawl inside of another man's skin and walk around in it for a while. If we can do that with our patients, they're more likely to believe us, trust us, and do what we say. So it's been out there a long time with more chronic disease, but there's very little that's been done in the emergency department setting. So that's some of the innovation that I'm going to talk about.
Yeah, I think that shared decision-making and empathic communication are things that have been published way more in the literature recently, and are things that doctors have probably actually been doing quite a long time. However, do you think you can change your stripes and become an empathic communicator if it's not already part of your practice?
Yeah, I love that question because it's about sort of innate interest and ability to do it. Now, let me get real for a minute and say I worked a shift yesterday and we got killed. I mean, I got to the point of forget the medical record, patient to patient to patient, making immediate decisions on the high acuity side of the area. And I was sort of laughing at myself that, man, empathy was out the door. Because when your pressure is less than 80, I got to keep you alive. Empathic communication is important to the family, but there are times when realistically we're trying to keep the physiology alive. So that's the first thing I have to say about it. The second thing is there are some docs that are better and more interested in it than others. And I think it kind of doesn't matter if you don't like it. Your employers, in the United States anyway, and I know Canada as well, want you to have patient satisfaction, and they want your patients to trust you. So we're going to have to do it, even if we're not good at it. So I think the bottom line answer to what you're saying is, even for those maybe third of physicians who are a little less interested and a little less skilled at empathic communication, they're going to have to fake it till they make it.
That's definitely one way of learning, and I agree with you. It's definitely something that I think we all want to do anyway. Maybe some of us aren't quite as good at it, but we definitely want to do it. The next question is, do you think this is needed in a low medical legal risk environment like Canada?
Oh, absolutely. It's already being done in Canada. I mean, let's look at the Ottawa Hospital's tagline that they have. The physicians carry their IDs on these lanyards, and the lanyards have an English phrase on it that says, I believe, I am yours, or I am here for you. And then it's said in French, and I'm not good enough for French to say. It's like je suis avec toi, or something like that. That means like I am here for you. I mean, that is about empathy, and it's happening in thought leader hospitals in Canada already. It's not about keeping myself protected from allegations of negligence, although it certainly helps with that in the United States. I mean, I've done over 100 medical malpractice cases as an expert witness in the United States. I kind of know what I'm talking about when it comes to why families sue, and they sue for accountability and the fact that they felt that the doctor never looked at or talked to or really communicated with their loved one who's now dead. It does help with that. But it is about establishing a relationship with the patient immediately that's long lasting. You know what the other thing it does is it makes you like your job and not burn out.
Right, right. I mean, the medical legal question is a little bit of a loaded one, but yeah, I don't really think it's necessary, but I was curious about your take on it. Um,
It's good in Canada, it's good in France,
yeah,
good in the United States.
yeah, good all around. So your pulmonary embolism research is practice changing. I mean, I use it every day on shift. I don't know how many times I've written perk negative on a chart and just been like, it makes me feel warm and fuzzy inside when I do that. Has your motivation in all of this research been driven by overtesting?
I think it's been driven by superficial thinking, meaning that it has always for years been okay to say, well, I just want to order a test to be sure. And it was a pseudo relationship. It was the failure to really think and address the problem. Just kind of like we do with it's not your heart when we talk about chest pain. That's not enough. We need to know what it is, which is part of the reason one of my fellows and great trainees is trying to understand the role of patient anxiety in low risk chest pain we don't have a good diagnosis for it. I mean, we need to get real with the problem and not just check a box and say, I did everything. And I think that this can extend out of just evaluating people with suspected pulmonary embolism into those with chronic pain syndromes and abdominal pain. Although I don't have enough life left and enough ability to take on abdominal pain, although I'm got a trainee who I'm trying to mentor through creating a selective perk rule for abdominal pain.
Wow, abdominal pain. You're really going into the black box.
Literally, I think the word peritoneum, if I remember right, it's Greek, is something to do with hide. So we'll talk about the abdomen some other day.
Yeah, chronic pelvic pain is third on the list. I hope.
I'll leave that to somebody else.
Leave that one for someone else. So, where are some areas in the emergency department that you think we see the most over testing?
It's in the intermediate risk areas. It's not so much in fast track or where everyone's triaged as low risk. It's the intermediate area that oftentimes has the more elderly patients, those with complex medical problems, existing cardiopulmonary disease, some history of cancer, any prior history of thrombosis in the area where I belong or in the area that I study. So it's those that are not perfectly clean in terms of their age and history, and docs just worst case things and believe that is the right way to do it. When so often, if you talk to the patient, what they're talking about is a relative exacerbation of a chronic condition. So I see it happening in the abdominal pain centers of the world, the place where the intermediate patients go. And it is very difficult to get the patients out of the emergency department without a lot of time and a lot of testing. And empathic communication may help with some of them. And I'm realistic. And when I say some, I believe 5 to 7%. I don't think we're going to stop CTing all those abdominal pain patients, but there's some low-hanging fruit we can go after.
5 to 7% is a pretty significant number when you consider the number of visits to most major emergency departments, though, in a year.
Right.
Yeah. So,
you know why I say that number, by the way?
Why is that?
That's the number that we found, and I will talk about this at the CAEP meeting, when we've surveyed physicians in real time when they're ordering CT scans of all type. And I try to call it low yield advanced imaging, but almost all of this is CTs of the head, chest, and abdomen. In about 7% of cases, the physician will actually admit on a form that they have a 0 probability, pretest probability of finding any emergency. It's probably higher than 7%.
Wow. So if they admit 7, like
it's probably higher.
It's probably a solid 10 at least.
At least. So a non-zero number of our CT scans are done by physicians who already believe that it is not going to show anything.
Like they're putting in the discharge order and the CT head order at the same time.
At least, mentally they are.
Right.
So that's where I call low-hanging fruit is, even in the tragic abdominal pain patient.
Yeah, for sure. Are there any areas in which you think we under-test?
That is a great question, and I'm going to answer with one that nobody's going to like, but it is psychiatric illness. We don't care about it. We don't think it's our job. And so we don't ask about it, and we don't test for it, except for the mandatory, are you going to kill yourself or somebody else question. And as a result, we do a disservice to ourselves, our society, and most of all our patients, because we think it is not our job to deal with anxiety and depression and phobic behaviors, but yet we treat those patients all the time or pretend to treat them instead of addressing the real issue.
Right. It's a huge number of our patients actually on a daily basis. Psychiatric illness. I mean, that's a great point. At this point, I'm going to be the patient, and I want you to pick any area in which we overtest, whether that's pulmonary embolism or what have you, and discuss with me as the patient how we can limit overtesting and why this is important to me.
Let me think how I did it yesterday. And I'm going to pick a relatively unusual example. And it's a lady with stage 4 lung cancer who is herself a highly functional, intelligent woman who comes in with shortness of breath. And I'm talking to you, a young male, as if you're this patient. So you've got a tumor in your lung, and I bet it's no surprise to you that this tumor itself could cause the symptoms you have. Now, people with lung cancer occasionally will get blood clots, and they can act kind of just like the tumor that you have, or they can fake us out. And if you do have a blood clot, and we were to give you a blood thinner, it might help prevent it from getting worse. And sometimes blood clots can even kill people. But what I really think is causing your problem is that the tumor is a little bigger, and it's making it harder for you to breathe. And it's even blocked off some of the airflow, and I think giving you a little patches of pneumonia. There's a chance if we don't do the CT scan that I could miss blood clots. But my best suspicion is that this is really coming from the tumor. And you've had a lot of CT scans, and your kidneys have been stressed. And when I do the lab measurement, it shows me your kidneys aren't functioning at full capacity. And I'm a little worried about giving you some more dye. So I'm fine doing that. There's really no blood test or anything else I could do. I could load you up with the contrast or do the CT scan, or we could do a trial of antibiotics, knowing there's a small chance that we didn't treat blood clots. So I'd like to talk to you about, what are you comfortable with? Would you like to try a trial of the antibiotics and the inhalers and see if you feel any better? Or would you really feel better if I went ahead and did the CT scan? And she said, the answer. I trust you, doctor. And I said, well, I want to trust us both. And she said, okay, let's try the augment. And so that's what we did. And I've got her phone number, and I'll call her later today.
Yeah, perfect. I mean, shared decision making is something that, yeah, I think that all of us should be doing like this basically daily, because there are so many gray areas in medicine, and we see so many diagnoses that can be one thing but are so much more likely another, and we can avoid a lot of testing this way.
And I think that example is not the low risk pleuritic chest pain patient that oftentimes gets CT'd that maybe you were thinking about, but I couldn't get it out of my mind because it's real and it happened to me yesterday. And plenty of patients with chronic diseases like cancer get way too many CT scans instead of a shared decision-making dialogue, which I believe and will talk about starts with the creation of empathy from the very first time you walk into the room and touch and look at the patient and engage them and let them know you're lucky you got me as a doctor, and I'm going to earn that trust throughout our entire visit.
That's a fantastic attitude to take into each patient if you're on a daily basis, that's for sure.
Well, and I also want to be realistic and say that the day decompensated, and it was not always like that. This is the reality.
Yeah.
This is a little bit like opera, and meaning that you've heard the difference between research and real practice is like opera and the real world. They're separate things, but it's what I try to do and strive to do, and it's what I'm going to try to present to the audience. And a lot of people are already doing this. I'm just going to put some words and some surveys and some active research and some interventions around what a lot of people in the audience are already doing and advocating.
Well, that is fantastic stuff, Jeff. I mean, super appreciative that you had a chance to talk with us today. I have a couple of bonus questions, which I'm hoping maybe you can tell me a couple of quick answers to. One, the PERC rule, Mirena and non-estrogen contraceptive. Do those count towards the PERC rule and the hormones?
Short answer is Mirena, Implanon, and Skylar. Those are progestin-only implants, as well as Provera injections, the Depot Provera. Do not fail the PERC rule. Do not fail the PERC rule. NuvaRing or anything that secretes estrogen that's put on the skin, or any estrogen-containing oral contraceptive, no matter how low the dose is, flunks the PERC rule.
Perfect. Reassured me for my practice for the last 4 years.
Yep.
Thanks.
I run a clinic for follow-up for patients that have PE or DVT that's sent out of the ER, and the birth control of choice I ask the ladies to use after they come off of their anticoagulation is Skylar or Mirena. I think those are the best.
Is Skylar another progestin secreting IUD?
I am not an expert in it, but it is like a smaller version of the Mirena. Sometimes ladies get uncomfortable because that Mirena is kind of big in the uterus. And Skylar is, like, as I understand it, is just a physically smaller version of it.
Okay.
Chemically similar.
Was not aware. You've gone over PERC and pregnancy several times, I think. I guess we'll never see prospective trials enrolling pregnant women probably, but using cutoffs for first trimester, you use 750, second trimester 1,000, and third 1,250?
Assuming the standard cutoff is 500.
Right.
Or I'll do proportional to that. If your cutoff is a hemosyl assay at 234 or whatever it is, I'll just basically use the proportional same for that. We've used it for years. I know many people have. Everyone wants a management study, and I don't know if I'll ever be able to carry it off, or anyone will. But I recommend, if they're PERC negative, then I follow it up with that stratified D-dimer, as you just said. It's perfectly fine to do lower extremity venous ultrasounds on both legs for every woman. It's no radiation. It's about the availability of the test.
Yeah, that's great stuff. Thanks so much for coming on the show today, Jeff. I'm at SockMavEM on Twitter. He's at Kline Lab.
Chris, it's great to be here. I look forward to seeing you at CAEP in June 2018.
Thanks very much, Jeff. It's actually going to be in May this year, a little bit early, May 26th through 29th, 2018, TELUS Convention Center, beautiful Calgary, Alberta. A couple of things we need to tidy up before we go. First, head over to capeconference.ca, check out the link to the meme contest. The best meme submitted by a medical student, resident, RN, etc. is going to win free conference registration for CAEP 2018. You can submit your memes to the social@cape.ca email. Thanks very much for joining us today, guys. I'm Chris Bond at SOGMobEM. He's Jeff Kline at Kline Lab on Twitter. Check out our new Facebook page for the CAEP Conference. You can also check out the @CAEP Conference Twitter account. Use hashtag CAEP18 or hashtag BestCAEPEver. We'll see you guys next time.